It's my very pleasure to introduce you to this satellite symposium that is going to deal with advances in dysphagia care for patients with stroke. I'm optimizing assessment and nutritional intervention. These are my conflicts. I don't think they're relevant for this talk, though. And that's the two of us. I'll do a quick introduction to the field. You know most of it, but it's always nice to have a bit of a reminder. Then I'm going to talk about early and accurate post-stroke dysphagia assessment for effective treatment interventions. And afterwards, we're going to hear her talk by optimizing swallowing function and nutritional status in patients after stroke. Okay. Yes. My presentation is largely based on these two papers that were kindly provided by Bendix Labert. He did most of the work. It's been published in Lancet Neurology last year and this year. I'm dealing with assessment of dysphagia after stroke and dysphagia after stroke with regarding to research advances in treatment interventions. So that's pretty much what we are going to talk to you about today. And you all know that dysphagia after stroke is a very relevant. I think that we see in the acute phase, we have data that claim that we're approximately between 40 to 50% who suffer from this. If we use instrumental assessment, we have a lot more that we see that are dysphagic, up to 75, some even say up to 82%, so that's quite a lot. And it's relevant since we know there's a lot of sequelae that we have to think about. We'll get to that in a minute. Time to recovery is usually approximately 12 days. But what we have to keep in mind, and I know many of you deal with this, is that 30% of our patients still, if they're dysphagic at the beginning in the acute stage, have an insufficient oral intake after 30 days. So we're getting to a chronic stage, and they are really difficult to deal with. And that's where we still need to do a lot of work regarding interventions and also regarding modern treatment. Dysphagia after stroke, it can improve, and we know it does eventually in a number of patients, and it can even resolve during rehabilitation. However, it can also persist in the chronic phase, as said before. And now the question I'll try to answer is, why is that a problem? So why do we have to think of it? And dysphagia after stroke is an independent predictor of malnutrition. That is relevant because we have a number of sequelae, one of which is sarcopenia, for example. So it's not an isolated thing that we're just thinking about the throat, but we have a systemic effects if a patient can't swallow properly. We have compromising effectiveness of rehabilitation. We know that dysphagia is associated with increased mortality. In this really large study, prospective multi-center study of more than 800,000 patients with stroke, dysphagia was associated with increased odds of in-hospital mortality. If we're looking at it, and that's very interesting, I find in this study that the most relevant factor for most relevant predictor for in-hospital mortality that they could identify was the severity of stroke at the beginning of their stay. So if someone got to the hospital and had a severe stroke, that would predict most likely if someone's going to die. The second factor, and I think that's really relevant in such a huge study, was dysphagia. The second most relevant factor to predict if someone's going to die during hospital stay, at least in this study, was the occurrence of dysphagia. Unfortunately, in this study, they missed to explain how they assessed dysphagia, but it seems to be relevant, at least to what I think and what this says. So we have another sequelae, which is reduced quality of life. We have an increased risk for hospitalization in general and their associated costs. So whoever has aspiration pneumonia is more likely to stay longer, is going to need more intensive care, and all of that is quite expensive. And now we should think of underlying causes. And I know you've heard a lot, especially if you went to the ICU session 2 days ago, but I'll try to get some of the major factors. We've seen this a number of times, but the swallowing network is of such relevance that I always think it's worth thinking it through again. So you know that we have a generator, a basic pattern that is created in the brainstem. And we have constant influences by cortical areas that will kind of shape this basic pattern. We need cranial nerves here to actually give commands to our swallowing muscles. And then we need a constant sensory feedback to adapt to what is happening in our mouth and in the pharynx and partly also in the upper esophagus. And this is all something that is affected by stroke, treatment, and other factors that we see in our hospitals. So you see cortical strokes that naturally have an impact on cortical function, and we know that the swallowing network is largely distributed in cortical areas, and we know if you have a cortical stroke, it is more likely for you to suffer from dysphagia. Subcortical strokes, similarly, if we're looking at the brain stem, so at the pons, and also at the CPG, you have the same thing. The organization won't work properly. And additionally, our patients are not just stroke patients, they're also patients in a hospital environment where they will get treated and where they also have troubles following their treatment. So one thing that we do is we give them lots of medications. Makes us good doctors, feels good whenever we prescribe something more. The thing is, all of the things that we do in good intention are not necessarily good regarding swallowing. So if we're looking at sedation, if we're looking at pain medication, especially opioids, we have a relevant impact on the function of the cortex. If we have patients that are in delirium, we know that's likely to impact cortical function and swallowing. We have direct trauma affecting cranial nerves, affecting swallowing muscles, and that can be a result, for example, from placing an NGT tube. That is a local trauma. It leads to edema. It's likely, and we've heard this before, that it leads to an impaired sensory function. And also we have reflux. We've heard about that. It also affects the sensory function. So we have a number of things that can influence swallowing. Now just a short excursus on the relevance of sensory function for swallowing. We need an intact feedback. We've seen that before. We can even see that in activation in the cortex, in the swallowing network. And we've done this study a couple of years back where we looked at the cortical activation during swallowing using MEG. So you can think of it of sort of an fMRI with a higher spatial resolution, better time resolution, and it's just the way that we think of the activation in the brain is just kept a little different, but in principle it is similar. And healthy subjects would get topical anesthesia against the pharynx. So we could imitate someone with sensory disruption in the pharynx. And this is what we saw, and they're healthy. This area that's usually activated during swallowing was largely reduced by this topical anesthesia. So it seems, and we could reproduce this with an air puff against the pharynx as well, you need a certain input to get a proper output. And this makes sense. It's like a general principle, but we have to think of that in swallowing as well. So that's why we are thinking about ice chip therapy sometimes. We need input to get the swallowing working again. And we've also seen, and this is a stroke population that we covered back then, that if a patient has a bad sensory function in the pharynx, it is more likely that he's going to have a bad general swallowing function, which is displayed by the FEDSS. That's a FEES score used in stroke patients. The higher the score, the worse the swallowing function. So we see this is connected. All right. Another thing we have to think about in stroke patients is the side of the hemispheric stroke. So if we're thinking about cortical stroke, not the brainstem strokes, we can have a stroke on the left side, on the right-hand side, and it can be both in patients that suffer from bleeding. That's usually a case where we have larger lesions to the network. But just think about it for a moment. In this study, we looked at the things that happen during certain time windows, and we know that swallowing usually takes about a second. We looked at it in 200 millisecond windows and saw that the activation was starting mainly in the left hemisphere, and then it would shift from the left hemisphere to the right hemisphere in the later stage of swallowing during the pharyngeal phase. And interestingly, we know that from symptom lesion mapping studies, patients who are right-handed and have a right hemispheric stroke are more likely to suffer from pharyngeal dysphagia, whereas patients with left hemispheric strokes more often suffer from oral stage dysphagia. So when you have a patient, you should always assess and try to understand, but it is more likely if you have a right hemispheric stroke that this is going to be crucial for the pharyngeal function, where most of the things happen that we have to have a closer look at, for example, in an ICU setting. Okay, and also, and this is the last one for the introduction, we have to think how swallowing can be, well, repaired, regained, and this is something that we've seen in studies that were done numerous years back, and we still see that this principle seems to work. In cortical stroke, we know that usually we have a relatively large network that is activated in both hemispheres if we're looking at an entire second. If we have a stroke like here, left hemispheric stroke, at first you have a downregulation of activation in the contralesional hemisphere, and it takes some time, but it seems there is a compensatory mechanism that this area that can compensate swallowing is growing compared to where we're coming from. So at first, swallowing is pretty bad in this stage, where you have hardly any brain left to swallow. But when this recovery mechanism works, this can partly compensate, and this can also explain why patients will improve their swallowing function after stroke just a couple of days. These neuroplastic changes usually happen within a couple of days, and this would explain why we have a relatively good spontaneous recovery rate, not to normal function, but at least improving a bit within the first couple of weeks. Yes. All right. So that was just a short introduction to the field, and now I'd like to talk about the advances in dysphagia care for patients with stroke, the optimizing assessment, and nutritional intervention. Okay. Let's have a look at this. Diagnostics. We have numerous diagnostics, and to spoiler this, we don't have the perfect one, but I know you know. We have a number of screening tools, among which are questionnaire-based ones. We have the MASA, which is famous. We have the E10 that has been used across the world. We have a number of water swallowing or multiple consistency tests, among which are the Daniels test, the 3-ounce water swallow test, the TORBEST, the GUS, the volume viscosity swallow. There's many, and they mainly look at clinical signs of aspiration, for example, coughing, throat clearing, drooling, stridor, hoarse voice. And we already have a guideline recommendation from the ESO, and it says, however, because comparative studies are missing so far, the optimal test paradigm has not been determined yet. So we have numerous tests, and I'm sure that even here in Germany, where many things are very standardized, each unit has their own test procedure. That's a very individual thing, and since we don't have those comparative studies, we can't really tell which test to go for. So use the one that you're experienced with, and there's some recommendations on which ones to use, and we'll get to that. All right. So let's start with questionnaires. Questionnaires are, in non-aphasic patients naturally, a pretty easy to use thing, and no one's afraid of them because it's questions. So it's very easy to use, and you can have a really low level to just do it. You'll get some out of it. Ask your patient about his or her swallowing. And this is the E10 is a swallowing assessment tool that has been evaluated multiple times. It has a good internal consistency. It has a high test, retest, and intra-item correlation coefficient. And we have standard values that help us a lot to see if we are passing a threshold that gives us indications of dysphagia, or if we see there are clear signs that we don't have them. Of course, questionnaire-based assessments have their weaknesses. Otherwise, we could do them. We wouldn't need fees. We wouldn't need other tests. But it's a first step, and I think it's a relevant step. What's really attractive about it, we have it in 36 languages. So it's a thing which allows us to compare between countries regarding research and also with our clinical experience. And we know that it is relatively accurate, and we have cut-off values that we can use. And I'm glad to see Antonio Schindler, because I know he's been working on this one here in the session. It has certain strength that you can see here. It can try to identify dehydration risk, malnutrition risk, respiratory infection risk, and it helps us to lead to a better adjustment of possible treatment in these patients or adaptation of nutrition, for example. So no questionnaire-based assessment, and any assessment is perfect. So it is a subjective measure. We are asking our patient, so we don't know if that's accurate. Sometimes we have patients who have the tendency to say it's worse than it actually is, and the other way around. We know in Parkinson's patients, for example, that many won't tell you spontaneously that their swallowing is impaired. We have similar effects here in such questionnaire-based assessments, and it's not specific for oropharyngeal dysphagia. And we have guideline recommendation and thoughts about it, and they say screening, either swallow-swallow tests or multiple consistency tests may be used, and this is similar for questionnaire-based assessments. We're not on the level that this is something comparable to fees, but it's a very relevant first step to get into the idea, and then to see if we need clinical swallowing examinations or if we need fees or video fluoroscopy, and get further steps. All right. There's multi-consistency tests, for example, the GUS or the VBST, that is basically using different consistencies, semi-solid, liquid, solid, you know all these, and then you go through items. They are not too difficult to use, and they may help us guiding the relevant assessment for a patient in an acute setting and even later. So it grades dysphagia in 4 categories: severe, moderate, mild, or no dysphagia. It recommends special diets and further strategies on the basis of its severity, and this is, I think, is always a strength. If you have a scale and you use it to score a patient, and you can have direct clinical implication, it's so much better than just saying it's severe dysphagia, and that's it. That would be very open. It's a lot better if you have a direct recommendation. So let's say, put him on semi-solid foods and he won't have oral fluid intake. That's something you can work with. You know, it's making it easier for those who are not too far into the field. And we have results of 2 meta-analyses on this one, detecting aspiration compared with instrumental dysphagia assessment. We have a really good sensitivity, but specificity is relatively low. But the Cochrane review said GUS was the best performing multi-consistency test in stroke patients, so it's something to think about if, for example, you can provide fees. There are others, just to mention, because this one has gotten some attention during the last couple of years and has been worked on a lot, especially in Spain. That's the BBST. It also allows a relatively high sensitivity in most modalities, but it won't allow for a high specificity in most of the aspects shown here. Now that's just a very general question that we ask ourselves sometimes, at least I do. Is it worth the effort? You know, you're doing this, you're doing your screening, you're doing your questionnaires, and after all, does this have an effect? And you've seen in the session before, SLTs have an effect in neurotrauma and neuro ICU patients, but do we see effects in stroke? And it seems that there is some evidence that we do have a positive impact thinking about swallowing, doing our screenings, and that's very relevant, because if you have a skeptic, show them this, and it's hard to argue with it. In this retrospective registry study with more than 350,000 patients, screening for dysphagia was just screening for dysphagia after stroke led to decreased in-hospital mortality. So thinking of it is the first step. Data from these 19 different stroke units showed increased probability of independence 90 days, so a relatively long effect, after stroke if dysphagia screening was performed within the first day. So if you can do it, try to do it early. It helps. And in this meta-analysis pooling 24 observational studies and 6 randomized controlled trials, dysphagia screening yields better outcomes regarding pneumonia incidence, mortality, length of stay in hospital, and dependency on care. And those are among the most relevant outcome factors that we have. So thinking of it, doing your screenings regularly and early really does have an impact on patient care. Okay, now let's have a look at a couple of predictors for dysphagia after stroke. We know that facial palsy is it. Aphasia or impairment of speech is a predictor. Clinical stroke severity. And there we have this study that also Bendix led back in the day, that we have certain cutoff values. For supratentorial strokes, we have a cutoff value of 10 or more. And for brainstem or infratentorial stroke, we have a cutoff of 6 points or more. And the thing is, this can give you an idea of who needs fees, who needs instrumental assessment. All of them should be screened. The thing is, this is kind of a rule of thumb. You may have patients who suffer from dysphagia who are not clinically who are not as severe affected as 10 points on the NHSS still suffer from dysphagia. But this gives you a rough idea of who definitely should be close to instrumental assessment. And this is pretty much the way we do it on our stroke unit. We do a lot of screening. Who fails will get instrumental assessment, but we also say even if we have someone who's above 10 points regarding supratentorial stroke, we would always try to do FEAS. But of course, we're in the very lucky position that we can provide a lot of FEAS because we have many experts around here. Clinical swallowing examination, something that is done regularly and that takes quite an amount of experience and quite an amount of time, is critically discussed. I tried to show you some data. So clinical swallowing examination typically includes medical history, screening of cognitive impairment. We've heard of that before, the relevance of cognitive impairment regarding swallowing function. We have the same thing in stroke because most of our patients are among the elderly. We have an examination of the oral cavity and cranial nerves, an evaluation of oral motor function, swallowing assessment of different consistencies, and it relies, again, on clinical signs of aspiration and dysphagia. And most of you will know this a lot better than I do, because I hardly ever do clinical swallowing examinations. You are experts in this. The thing is, we have a number of things that we see: coughing, throat clearing, coated voice decreasing, laryngeal elevation during swallowing, but only few studies show patient benefit. To be honest, this in one way is disappointing, but in the other hand can be motivating. We need more studies to show that it works. The studies that we've had from the past are negative or just slightly positive, but the numbers of patients that were included is usually small. We use different clinical swallowing examinations that were included or part of it, and we need standardized and randomized controlled trials regarding this to actually prove this. I think this can be motivational in the way that we still have to prove that it actually works. I think it's worth the effort. And then we have, of course, instrumental assessments and the two gold standard methods. Of course, FEAS, endoscopic technique, and the video fluoroscopy. And there's a third one. There's you in this third row. Of course, there is high-resolution manometry, but this is not a standard in stroke care, because usually, for what we know, in the particularly oral and the pharyngeal phase are the ones to look at in stroke patients. But of course, if you want to have a look at the esophageal state of swallowing, you will have to use HRM to have a closer, have a better idea of what is happening there. All right. So why should we use instrumental assessment? It takes time, it takes efforts, and it takes money. You need to buy them. and you need someone to be trained in it, and the patient needs to be worked on. So that's quite an effort again. We have superiority of instrumental diagnostics compared with CSE, that's a question, and we know that we find I'm using instrumental assessments dysphagia significantly more often than just using clinical swallowing examination. We have an increased sensitivity that way. Clinical swallowing examination with a multi-consistency test by nurses and detailed evaluation by SLTs both showed low diagnostic agreement with instrumental evaluation. So this is still very much the gold standard to compare anything to. And in a retrospective study, only 31 of patients with stroke had an appropriate diet recommendation before fees. So fees can help you, and we've seen this before, to give a more liberal or to give a more restrictive diet to what we see. And I would really like to stress the aspect that instrumental assessment often is not a tool to forbid your patient certain a certain form of nutrition. It's often a thing that makes it safer to have a liberal nutritional therapy. All right, what are the pros and cons? Fees and video fluoroscopy. Most of you know the fees is relatively cheap. It's available at bedside. You can evaluate secretions and sensation. You don't need any contrast agents. It's doable in less cooperative patients, and this is really relevant in stroke because we have a lot of patients who suffer from delirium, who are not properly orientated, and fees is something that you can still do in most of them. You would have to have a lot more compliance doing video fluoroscopy in them. Of course, there is a large disadvantage. You only have a visualization of the pharyngeal swallowing phase. You won't really see a lot of what is happening in the mouth, and you definitely won't see anything that is happening in the esophagus except for reflux. But then you pretty much see the result. You don't really see what is happening during this occurring. The video fluoroscopy is attractive regarding that it captures all swallowing stages. It allows for a direct visualization of aspirations and silent aspirations. It has disadvantages. As said before, you need a certain patient cooperation. You need contrast agents. It has and includes always radiation exposures, and you will have to transport the patient to a ward. And if it's a patient on a monitor who still needs to be monitored, this is always related to certain risks, and it's always more of an effort, I feel, than doing a fees bedside. Okay. Which protocol to use? And this is the one that we use, and I said before, I think it's really attractive if you use a score that gives you a clinical implication and a recommendation of what to do. And we use this one. This is the FEDSS, the Flexible Endoscopic Dysphagia Severity Score, a score from 6, which would be the worst, to 1. And it's pretty easy to perform. You look at secretions. If you pass it, you use a semi-solid consistency. If you pass that, you use liquids, and then you can use soft solid foods. And usually these examinations, they take approximately 6 to 8 minutes in a patient once you have if you have the apparatus there. All right. It has a high inter-rater reliability, and it can be used as a valid predictor of complications for pneumonia, need for intubation, re-intubation, extubation failure, and worse functional outcome. Okay. Another question that we should always ask is when, and not only whom and how. So we've done the whom and the how. Now I'll try to get into the when. Most respiratory infections occur during early stages of the disease. In this registry-based cohort study with more than 60,000 patients, that's large regarding our field, a delay in dysphagia screening or clinical swallowing examination was associated with a higher probability of developing pneumonia. 6 hours delay, so that's just a fourth of a day, increases the risk of pneumonia by 36% in this study. So look at your patients, try to look at them early. In this prospective observational study with more than 3,000 patients, a delay in screening of 4 to 72 hours, that's a relatively large span, we see an increased odds of pneumonia and disability on discharge. and delay of screening for more than 3 days, we had an even higher odds of pneumonia, increased length of stay in the hospital, disability and discharge, and motility. So again, the hard factors, the hard outcome factors, parameters. So what would we propose? And this depends on, and should be practical, if you have a dysphagia expert or not. It's no dysphagia expert, so I assume that you guys won't need this, because whoever's here, I guess, is pretty much on the side of dysphagia expert. However, sometimes you have, you have numerous hospitals that don't have dysphagia experts, and you still need a proper recommendation. So we figured it would be good if you have a dysphagia expert available to use a water swallowing test and clinical predictors. And if you have a low risk, it's okay to go for total oral intake. But if you have a high risk, factors that would indicate for dysphagia, use a more detailed assessment, preferentially instrumental diagnostics. So if it's at night and there's no dysphagia expert available, you may use a multi-consistency swallowing test and then decide on oral intake from that. And if you're not sure, there's always the chance to do fees the next morning, but try to do the assessment early to identify those who are at risk. To sum up, we would then say screening for dysphagia, do it really early. Are there signs for aspiration? Are there clinical predictors of dysphagia? If yes, go for instrumental assessment if you can. This will help you during the acute stage regarding these questions. Do we have a safe swallowing? Do we have a good swallowing efficiency? And then, only by the time a little later, after the weekend, you can have a closer look at the impairment profile, the prognosis. Do you eventually need PEG? That's the question. And are there contextual factors? And I quickly show you these, and after that I'll be done with this talk. Predisposing factors, we have aspiration, decreased cuff reflex and strength, and others, and we have diagnostic consequences that we can get from this. So have a look. If we aspirate, it might make sense to do an instrumental dysphagia assessment. Decreased cuff reflex and strength. Is there a cuff assessment? Is there possible technical support for this? Do we need oral hygiene assessment, a very interesting field regarding microbiome right now? Do we have patients who are on immunosuppressants? Many of our patients are polymorbid, and many of them take prednisone, stuff like this. And do we have to think of them differently? Are they at a particularly high risk? Seems like it. And do we have decreased resilience to existing infections? Assessment of frailty. They're polymorbid. We have to look at that. And next steps, and I won't get into this, it's more a teaser for what is coming in other talks, is for studies, definitely, define what you give your patients. And the ITSE framework is really helping for the last couple of years to get further to see what adaptation is actually necessary and makes sense and which is standardized. It helps us for comparison reasons. Dietary intervention is the large thing. Nutritional interventions, oral hygiene, and then we have newer kids on the block. They're not that new anymore, but there's still something to look at. So we have TDCS, TMS, the neuromuscular electrical stimulation, pharmacological agents you've heard before, and of course pharyngeal electrical stimulation. And this is how I like to sum up. Thank you very much for your attention.